current 5-year survival rate for patients with lung cancer is only 5%. The survival rate for esophageal cancer even lower. An improved outlook for both diseases, of course, is only possible by diagnosing more cases at an earlier stage of disease and beginning prompt palliative and curative therapy. The objective of this week's edition of Audio Digest Surgery, Volume 18, Number 3, for the week of February 10th, 1971, in which 4 surgeons with wide experience share their diagnostic and therapeutic approaches to carcinoma of the lung and esophagus. On side A of this program, Frederick G. Pearson of the University of Toronto Faculty of Medicine discusses the non-operative diagnosis of lung cancer using mediastinoscopy, aspiration lung biopsy, and pulmonary angiography to improve quality of survival by avoiding unnecessary thoracotomy. Then, Dr. Pearson joins Edward J. Beatty of New York City's Memorial Hospital for Cancer and Allied Diseases and Paul C. Adkins of Washington, D.C.'s George Washington University School of Medicine for a discussion of the treatment of lung cancer, pre- and post-operative irradiation, standard lobectomy or pneumectomy versus radical lobectomy or pneumectomy. On side B, Dr. Adkins covers many considerations in the surgical treatment of metastatic lung cancer. And to conclude the program, Dr. Beatty describes diagnostic methods and preoperative irradiation, total esophagectomy, and colon interposition in the management of esophageal cancer. Moderator during the next 60 minutes is Thomas B. Ferguson of Washington University School of Medicine, St. Louis. Dr. Ferguson, will you take over now, please?
The first speaker is Dr. Frederick G. Pearson, bronchogenic carcinoma diagnostic methods short of thoracotomy.
I'd like to review today 3 procedures: mediastinoscopy, aspiration lung biopsy, and pulmonary angiography. And each of these is used in the preoperative assessment of patients with lung cancer, but there is still controversy among the thoracic surgical community as to the exact or precise application. And I would like to draw from our own experience today and try and define this application a little more clearly. Of the 3, mediastinoscopy has had by far the greatest impact on our management, and I'll deal with it in a little more detail. Our experience with this procedure dates back about 10 years, and we really have come to the conclusion that it can be usefully applied in an almost routine fashion to the assessment, the preoperative assessment of patients with presumably operable lung cancer. And if we look at the risks and complications in reviewing our own hospital experience up to 1967, the complication rate was under 2%. Left recurrent nerve palsy is the commonest of these. A pneumothorax on the right side is the result of breaching the mediastinal pleura and biopsying anthracotic lung, which is mistaken for lymph node. Now, this is in the right paratracheal region that it occurs. It's not a very serious complication so long as it's recognized, and it really is completely avoidable with experience. I think troublesome bleeding is the most worrisome hazard because of the limited available exposure. And vigorous peroperative hemorrhage has occurred in our own series in 3 patients, once from the pulmonary artery, once the azygos vein, and in a 3rd patient from a small bronchial vessel which was avulsed from the concave surface of the aortic arch. And it was this latter bronchial arterial bleeding was the only case in which thoracotomy was required to achieve control. Certainly, mediastinoscopy is as safe as scalene node biopsy, but is a much more informative exploration. It affords access to the superior mediastinum from suprasternal notch to the subcarinal level, but there are some important blind areas. It doesn't bring you into the anterior mediastinum in front of the great vessels, and this area does contain nodes which commonly drain tumors in the left upper lobe. Nor can one reach the inferolateral aspect of the aortic arch on the left side, and on occasion involved nodes lying low in the posterior part of the subcarinal compartment are missed. It is possible to break through or breach the mediastinal pleura on either right or left side and explore the apex of either hemithorax in patients with superior sulcus tumors. The tumor can be felt, and you can introduce the scope, and you can obtain, if necessary, a direct biopsy either with a forceps or by aspiration. Caval obstruction is not a necessary contraindication. With a little extra care, once you reach the pretracheal fascia, the loose areolar tissue around the trachea has no venous tributaries at all, and bleeding should not be a problem. And we have successfully completed the procedure in 23 patients in this particular group. Now, in patients with presumably operable lung cancer, mediastinoscopy frequently provides useful information which relates both to operability and to technical resectability. And on occasion, it is the only technique which provides a tissue diagnosis short of thoracotomy. We need more precise information about the fate of patients with superior mediastinal extension, but our own interpretation has led us to date to actually avoid thoracotomy in 1 in every 4 patients in this group. The findings have prompted modification of treatment in a few patients and led us to combine irradiation and surgery. Here, some of the alternative procedures which are available to define superior mediastinal extension, and I will only enumerate the apparent advantages or disadvantages of each. Anterior mediastinotomy is a technique of exploration through the 2nd or 3rd intercostal space, usually through the bed of the cartilage, and has the advantage of providing information about the anterior mediastinum. So it is particularly applicable in patients with primaries in their left upper lobe. And we are now using a modification of this technique to supplement mediastinoscopy for patients with primaries in that location. It's the only location that spreads into the anterior mediastinum. Jacoby in Denver has reported a small experience with anterior mediastinotomy, which is really a mediastinoscopy without a mediastinoscope. He uses direct techniques for exposure and feels that it is more surgically acceptable. The low incidence of complications in our own and in other reported series hasn't prompted us to pursue this particular modification. Harkin's lateral cervical approach is technically more difficult and does not provide any additional information. Now, gas mediastinography will quite clearly outline enlarged nodes in the superior mediastinum, and indeed in more peripheral areas along the tracheobronchial tree, but it has the decided disadvantage that there is no tissue obtained for biopsy. I think the information we obtain at mediastinoscopy precludes the need for scalene fat pad biopsy in these patients unless they have actual palpable nodes. Now, there has been a resurgence of interest in percutaneous aspiration lung biopsy. And this is using a modification described by Nordenstrom with a relatively fine bore needle. And this modification has reduced the hazards. And if we couple this with the increased accuracy of cytodiagnosis, it has become, I think, a decidedly useful procedure in selected patients. Under local anesthesia, a 19 or 20 gauge needle is introduced percutaneously with the patient prone or supine using single plane fluoroscopy and image intensification. With the patient breathing quietly, the point can pretty reliably be introduced into lesions as small as 1 centimeter in diameter. The needle is then rotated clockwise and anti-clockwise, withdrawn, material expressed by inserting the stilette onto a semi-opaque glass slide, fixed in 95% alcohol, and stained for cytologic assessment. As one might expect, pneumothorax is common, but rarely troublesome, only 5% requiring either aspiration or tube drainage. And post-aspiration chest x-rays should be taken for this reason. But there have been no other significant complications in our own experience. The greatest potential objection is that tumor may be implanted along the needle track. Well, we have not seen this, although we've only been using it now for 3 or 4 years, but Nordenstrom, reporting on several thousands of these since 1955, has not had one documented case of tract implantation. Now, what is its application in bronchial carcinoma? I think it's most useful in providing a tissue diagnosis in the patient with lung cancer who is not operable because of age or physical condition, and when a diagnosis cannot be achieved short of thoracotomy. There will be a small number of patients in whom we make a provisional diagnosis of cancer, and needle biopsy tells us that it's a benign lesion, and the patient may be spared a thoracotomy. The third advantage doesn't sound particularly scientific, but I think it is a practical one. It is possible to obtain a tissue diagnosis within about 24 hours of the patient's admission to hospital, and this may greatly expedite the otherwise prolonged investigation which some of these patients with suspected cancer go through. Now, a definitive diagnosis is usually most difficult for us in patients with peripheral lesions, and I think it is here that aspiration biopsy has its best application. Pulmonary angiography has been available to us for many years, but is still, I think, applied only in a very limited way to investigating patients with lung cancer. Our own experience dates back about 13 years, and I'm sure that it is useful in a very small number, but in certain selected situations. It's most useful for the determination of technical resectability. It won't give us a tissue diagnosis. The superior vena cava, the main pulmonary artery, and its lobar branches are very clearly defined in the angiogram. And so it is useful if we have lesions which lie along the right side of the superior mediastinum, which might involve the vena cava. I would recommend it if tumors are tucked in under the aortic arch on the left, that the left pulmonary artery is relatively short, and it may show involvement of the main pulmonary artery itself. And on occasion, it's quite useful in patients where we would entertain a lobectomy, but feel that for reasons of operative risk or condition, we couldn't do a pneumonectomy. And it may tell you quite clearly that you can or cannot do the lobectomy on the basis of the lobar arterial involvement. Detail on the distal side of the pulmonary circulation in the pulmonary veins and heart chambers is much less precise, and I don't think it's very dependable. I think we can summarize the contribution of some of these procedures to the management of patients in our own hospital. Now, there isn't any evidence that we have affected any decrease in the mortality rate for unselected patients with bronchial cancer. It's still a dismal 5-year survival rate of about 5%. And it's only identifying many more cases of carcinoma at an earlier stage that this is likely to change. But I think we sometimes become quite blinkered in our pursuit for better survival and neglect consideration of the quality of survival, which may be equally important. And a great deal of progress has been made in the selection of patients for treatment. And the morbidity due to unnecessary thoracotomy has dropped from 64% in 57 to 77% in 1963, and now sits at about 94%. And during the past 3 years, the mortality rate is now down to less than 5%, and this, I'm sure, is due to improved technique and post-operative care, but it is as well due to a more careful selection of patients before submitting them to operation.
Dr. Pearson, there are a number of questions related to the technique of mediastinoscopy. They want to know what type of general anesthesia you use, how you do it, what instruments you use, in other words, what manufactured instrument you use for the mediastinoscope, and so on.
They're all done under a general anesthetic with endotracheal intubation, and from the time you make the incision in the neck, the patient is on positive pressure respiration, so that there's no hazard of their aspirating air into a divided vein. The incision is about a 2-inch skin crease incision centered at the suprasternal notch, and maybe 2 inches above the notch. You'll find with the patient's head extended, if you put it right in the notch, it's cosmetically quite unpleasant. The scar will migrate down over the sternum, and it's quite noticeable in a woman, so it's better to keep it high. The instrument we've used is the original scope, which was made for Carlin's by Stille, and they no longer make it. Now, we still have two, and we're still using them. I still think it's one of the nicest tools available. The closest thing to it, I think, is made by Pilling now here in this country, but I've had no experience with it.
Do you do mediastinoscopy routinely, and if you use it routinely, does it sometimes keep you from doing bronchoscopy and or scalene lymph node biopsy?
We do use it almost routinely. I think we might have a patient with a small peripheral primary or an occult carcinoma, one that isn't radiologically evident, and yet we've diagnosed it at bronchoscopy. They don't spread to the nodes, and I wouldn't use it there, but in all other situations we have. But we combine the bronchoscopy most frequently with the mediastinoscopy. They're both done under a general anesthesia, therefore. And I do the bronchoscopy first, since you may well find the information you need, a diagnosis, and that the patient is not operable at bronchoscopy, and you don't need to do the mediastinoscopy. Scalene node biopsy we don't use at all unless we have palpable nodes here and we simply want to obtain a diagnosis in something we know or assume is already there.
There are a number of people that you've disturbed by putting a needle in those solitary nodules. They want to know what you would do if you found a patient with active tuberculosis on the nodule.
If we found the patient had active tuberculosis, I'd be very pleased that we made the diagnosis. We'd put the patient on drugs, and I don't really think it's imaginable with the few organisms that I assume the person who asked that question is concerned about spread. We would spread that probably just as much, actually operating on the patient and doing a thoracotomy to make a diagnosis.
They want to know if you put the aspiration needle or the biopsy needle into patients who have cavitary lesions.
Putting the needle into a cavity, I suppose if the cavity is right against the visceral pleura, there might be a greater risk of having a substantial pneumothorax. But remember, this is a very small bore needle, and we stick needles into blood vessels all the time without giving it a thought, and larger bore than these. I don't think that creates a problem.
And when a biopsy shows a benign lesion, are you satisfied that there's not a cancer behind that area where the biopsy was taken?
I think it hasn't proved very useful for patients with benign lesions. We don't usually get a positive biopsy in a benign lesion.
If you have a negative aspiration on a solitary nodule, would you not operate on the patient in following?
If we have a negative biopsy, we then are obliged to operate on the patient if he's operable, to find out what is there. But I pointed out where I think it's most useful is in a patient in whom you don't intend for a moment to take it out if it is a cancer, but you don't know whether it's a cancer. And this saves the patient a thoracotomy.
There are a large number of questions, which I'm going to throw open to the panel, relating to two situations. That is the value of pre-operative irradiation combined with surgery, the value of post-operative irradiation combined with surgery. This is for lung carcinoma. And the relationship of survival in radical lobectomy or radical pneumonectomy compared to the standard procedures. Dr. Beatty, Ted, you want to start?
The first question has to do with preoperative radiation. We feel that there are two places that preoperative radiation in lung cancer seems to have definite benefit. I think that one of these, of course, is the superior sulcus tumor, beginning with the work of Paulson, and we're in agreement with this to use approximately 3,500 rads of preoperative radiation to see if it can be removed. The other area where we feel that has made a difference has been in chest wall invasion. That when there's chest wall invasion, we've been able to have a cure rate of 10% with preoperative radiation plus surgery. Generally speaking, however, preoperative radiation in any other area, to my knowledge, has not proven to be of any benefit. And if you give high doses, 4,500 rads on up, you can increase your morbidity and mortality rate of your surgery, especially if you do pneumonectomies. The other form of radiation therapy, which is not used very much, and I first personally became aware when I got to Memorial, is implantation of radioisotopes. The Memorial Hospital series of superior sulcus tumors treated by implantation of radioisotopes, usually radon seed in those days, now iodine-131, had a 5-year cure rate of 16% of implantation plus radiation therapy. Also, one of the reasons we do so many thoracotomies on lung cancer, even though other people think they're non-resectable, and so do we, is that if they're non-resectable, we implant them with iodine-131 seeds. And we are currently running an 8% 5-year survival rate with implantation of non-resectable, which we consider non-resectable lung cancers. So I think that's a form of radiation therapy that's been neglected. External radiation therapy alone is well under 1% curable. And post-operative radiation therapy, as far as I'm concerned, is palliative. It hasn't seemed to have made any significant impact. And I'm interested in the other panelists' ideas on this first question, maybe, Tom.
Right. Dr. Atkins?
Well, I think I'd go along with Dr. Beatty as far as the superior sulcus tumors are concerned. I think this is one of the major breakthroughs in the last 10 years, combining radiation at 3,500 R with resection. And to some extent, we go along with the chest wall invasion. If it's gross and obvious, we would probably irradiate them, and then if there were not contraindications in terms of howler involvement or other spread, go ahead. One will occasionally run into the situation where you have a peripheral tumor mass which seems to be abutting against the chest wall, but there's no evidence of rib destruction. It may be just invading the parietal pleura, and in those cases, we would not irradiate, just go ahead and operate, and if possible, do a block resection of the lung and chest wall, so that we would not use it as a routine. We've had no experience with the radon seeds. I think that's an impressive figure of 8% versus 1% with the addition of radon seeds.
Brett?
I might try and generalize a bit. I think that preoperative irradiation is probably useful in any situation where you're likely to be cutting close to or potentially through small amounts of the primary tumor. And the superior sulcus tumor is a first-class example of this. They have low incidence of node involvement, but it's a very hard place to clean it out. So theoretically, at least one of the assumptions I think we make is that we are able to destroy, on occasion, cells on the periphery of the tumor. Now, there are other situations where that also applies. I think the chest wall may be one of them. And occasionally, patients who have a lesion very close to their carina, and most of us don't do carinal resections for primary lung cancer, I think that may be a useful place to give the patient a limited dose, just the type you use for a superior sulcus tumor, 3,500 rads in 3 weeks. There are a fair number of cures reported for bronchial stump recurrences with post-operative irradiation. It's about the only place it ever does much good, but there again it's the primary that's been left behind. We're using it for this group of patients with ipsilateral involved mediastinal nodes, and we're using it purely on speculation that once again we may be leaving tumor in microscopic amounts in glands or lymphatic channels. But I think we're likely going to find that it isn't local recurrence that kills those people. It will be the bad biology and hematogenous spread.
Let's ask the panel to comment on the other part of that question, which was standard lobectomy or pneumonectomy versus the extended lobectomy or pneumonectomy. They also want to know the morbidity and mortality as well as the cure rates, if any different. Ted, I think, again, you're from...
Probably. This was popularized, I think, in this country by Bill Cahan at Memorial, who started this. And we have done a fair number of attempts to remove the lymph nodes as much as possible along with whatever part of the lung you take out. It's not completely resolved to statistical satisfaction, I think, is the quick answer to the question. Comparing pneumonectomies with and without lymph node dissection, we found that there was no increase in morbidity or in mortality rate of the pneumonectomy series. In fact, pneumonectomies without lymph node resections had a higher mortality rate in our series than the ones that did. And the same was true also of doing the so-called radical lobectomies. As we analyzed the figures, the patients who survived pneumonectomy had a 30% 5-year cure rate, and those who survived the radical pneumonectomy had a 37% 5-year cure rate. And it was not statistically significant, but it was in the right direction, so to speak. In the so-called radical lobe, which you might say, well, how in the world can you do a radical lobe? The fact remains that in the radical lobe of those who survived operation, of course, a lobectomy has a much lower operative mortality rate than a pneumonectomy. Should be 5% or less on properly selected cases, surely. The so-called simple lobectomy in our hands, those who are surviving that, turned out to be a rather poor cancer operation. It had a 5-year cure rate of about 26%, a little bit less than the so-called simple lobe. For some reason, the radical lobectomy group had a 5-year cure rate in our series of 44%. So we came to what seemed to us a fairly logical conclusion that you should use the operation with the lowest operative mortality rate that gave the greatest cure if you could. Now, of course, the problem is that sometimes you can't do a lobectomy just because of the location of the cancer and you're committed to doing a pneumonectomy. It hasn't been resolved. We have this under study at the present time, although I'd like to introduce one note of warning that we've come into. In my opinion, it is possible to dissect the mediastinum out better than we ever used to think, and I think we've run into some problems that we're in the process of study that you may get some lymphedema of the lung if you're thorough enough.
Other members want to comment on that? Dr. Atkins.
I don't have anything over and above what Dr. Bay said. We certainly don't have any large series like Memorial. I think we do and have become a little bit more aggressive in extending the procedure, if necessary, by virtue of the extent of the tumor or lymph node involvement, to more frequent intrapericardial dissections or taking the pulmonary artery medial to the superior vena cava when necessary. The only comment I would make is that our mortality associated with the intrapericardial dissections has not been really any different than with the standard type of pneumonectomy. The incidence of arrhythmias in the postoperative period has been about twice as much as with a routine resection.
Dr. Pearson.
It seems to me, though, that there is evidence in some other series that if radical pneumonectomy has been applied to that group of patients with lymph node involvement, if that's the reason for its application, that the results have really been quite dismal, and I think both Dr. Ochsner in this country and Brock in England have abandoned the procedure for that particular situation. I would have thought that one might choose to do a radical pneumonectomy or a radical, I assume that's a radical upper lobectomy. You can hardly do a radical right lower lobectomy and clean out the mediastinum, I think. But nevertheless, I would have thought you'd want to apply that if your pathologist told you that the nodes you took out from the region of the main bronchus or up in the tracheobronchial angle were involved. If, on the other hand, all the nodes you sent him from that area were not involved, it would seem to me unnecessary to add that time.
I think one of the problems that we have, if you take an analogy of breast cancer and you clean out all the lymph nodes in the axilla of most patients with breast cancer, if the pathologist wants to find cancer in those lymph nodes and serial resections all the lymph nodes, you can find tumor in all axillae. As you well know, serial sections of axillary lymph nodes is not standard pathology, nor is serial section of mediastinal or peribronchial or hilar lymph node standard pathology. So obviously, as we well know in breast surgery, the results of radical surgery do better when there's not a lot of disease in the axilla, especially at the higher level of the axilla. This has been well substantiated in the pathologic material at Memorial Hospital, although most places don't bother staging the level of axillary lymph nodes. And I think that if there is any point in getting the mediastinal lymph nodes out, obviously is going to work better if there is microscopic cancer that you have to find by serial section rather than if there's gross nodes that any pathologist can see the cancer in, if you see what I mean. So that I don't claim that the answer is proven, but I would hasten to say that I don't think the answer is proven that you shouldn't take the lymph nodes out. Lung cancer is a lot more malignant form of cancer than breast cancer, so that a little bit of cancer in a lymph node of a lung might mean a lot more meaningful than a little bit of breast cancer in an axillary lymph node, if you see what I mean. So I think you just get to argue. We don't have the controlled figures on it. It's just interesting that it seems to go in the right direction.
The conclusion of the group discussion on treatment of lung cancer also concludes this side of your program, Doctor. Side B, featuring discussions on the surgical management of metastatic lung cancer and the management of esophageal cancer, can be heard by just flipping over your recorder's cassette or 2 reels. Continuing a program on carcinoma of the lung and esophagus, this is Side B, Audio Digest Surgery, Volume 18, Number 3. Here again, our program moderator, Thomas B. Ferguson.
Your next speaker. To speak on surgical management of metastatic neoplasms, Dr. Paul Atkins.
In a clinical setting, the majority of patients that are seen with pulmonary metastases have multiple metastases, mostly in both lungs, and frequently will have also bony metastases, liver metastases, and so forth, and there is nothing one can offer surgically except possibly in the occasional case a diagnostic biopsy. However, occasionally the situation is a little bit more favorable and lends itself to some sort of surgical intervention. And there's a few thoughts about this subject that I'd like to cover. I think most of us are familiar with the literature on the feasibility of resection of the solitary metastatic lesion, particularly in the patient who has done well from the initial operative procedure. However, not infrequently one is faced with a bit of a dilemma as far as selecting the type of case in which one should consider surgical intervention. Now, these are some of the criteria which have been advanced for the selection of cases where a presumably metastatic lesion may appear early on following resection of a primary, where the primary was a highly undifferentiated or anaplastic lesion, or other considerations may enter. Adequate control of the primary lesion, of course, is a sine qua non for consideration of resection of pulmonary metastases. There should be no other evidence of metastases to bones, liver, and so forth. Question of the number of metastatic nodules frequently comes up, and we have found that doing full lung tomography is often of value in defining small lesions which were not apparent on the routine films. The cell type of the primary, of course, is a major consideration, and the time interval between the resection of the original primary, a definitive resection, and the appearance of metastases has been brought out as an important factor in considering the feasibility of surgical intervention. However, when all these are fed into the equation, sometimes, again, it's a little difficult to come up with any objective findings or rationale for making a decision. Now, one of the things that we have found in conjunction with Dr. Donald Morton at the National Cancer Institute is a technique for measuring tumor doubling time. One plots the diameter of the mass in the lung against the time, and as the doubling occurs, it's a function of the diameter, the transverse diameter of the tumor mass, and plots this on semi-logarithmic paper against time. You can get a linear definition of the tumor doubling time, and that is the time it takes for one double. And we found this to be considerable value, and it seems to correlate well with not only the time interval between the resection of the primary and the appearance of metastases, but also in terms of survival. And it does give an objective method of measurement. In some instances where there are several metastases, they may double at a different rate, and they can be plotted on the same curve with one tumor mass growing more rapidly than the other. Why this occurs, I don't know. Individual biological potential, perhaps. Generally, people with sarcomas who develop pulmonary metastases are considered to be very poor situations prognostically, and generally this does hold true, except for some of the osteogenic sarcomas had a rather long tumor doubling time, and in some of these people, an aggressive treatment of the pulmonary metastases seemed justified on the basis of this long doubling time. The survival of patients in this particular series, and these are 89 patients who for one reason or another developed pulmonary metastases and were not treated surgically by virtue of evidence of recurrence elsewhere in the body or for a number of reasons. The patients with a tumor doubling time of less than 20 days, at 6 months, a little over 60% were alive, and at a year, only about 9% were alive. The patients with tumor doubling times between 20 and 40 days, it was an intermediate group, but they were all dead in a 18-month period, and the tumor doubling times untreated over 40 days, they lasted out until about 2 years. And this is regardless of the histology of the malignancy. And those patients that were treated, again, there were some interesting figures, and that is the patients with the tumor doubling times under 20 days did not do well. Even if the metastasis was resected, they were dead in 18 months, doing a little better than untreated, but prognostically not well. The intermediate group doing somewhat better, and then curiously enough, those patients who had a tumor doubling time more than 40 days, even though some of these required bilateral stage thoracotomy for resection of metastases, all of these patients survived up to 5 years, 11 patients. And I think this is an extremely interesting figure and justifies evaluation of the doubling time as one of the major factors in making a decision about the aggressive therapy of pulmonary metastases. Now, going to another area which has been of some interest to us, with good surgical treatment of primary carcinomas achieving more and more potential cures, and with the life expectancy of people increasing, one must take into account the possibility that an abnormality seen on a chest film in a patient who has had definitive treatment of a carcinoma elsewhere in the body may not represent a metastasis. It may be something else. And to this end, we studied a series of 50 patients who had had a definitive, presumably curative treatment of a carcinoma elsewhere in the body, who showed up with an abnormality on the chest film, and followed these patients through. All of these patients had no evidence of local recurrence of their primary carcinoma. The interval between the treatment of the original malignancy and the appearance of the pulmonary lesion, when broken down into those patients who eventually showed a metastatic lesion opposed to those in which the lesion was unrelated, was different on a time basis, the metastatic lesions appearing earlier by about 2 years. On the other hand, if this series is broken down as far as the site of the original primary is concerned, there is no statistical difference to help one differentiate or prognosticate whether the abnormality on the chest film is a metastasis or whether it's an unrelated lesion. The radiographic appearance was also of not too much help in that although the majority of the patients who had an abnormality showed the solitary nodular density, which is characteristic of metastasis, almost a third of this group, the lesion proved eventually at operation to be unrelated to the original primary. The most common appearance is solitary nodule. The others were not of sufficient frequency to really be also helpful. All of 50 patients in this group that I'm talking about now were subjected to operation after the appropriate workup, and the findings at operation were of some interest. In those patients who had a breast primary and who were operated upon, majority of these turned out to have a lesion which was unrelated, either a new carcinoma or a benign lesion. The same was true of patients who had a primary of the larynx or the tonsil, and that all of them had an unrelated lesion. On the other hand, patients with a primary carcinoma in the genitourinary tract, the colon or the rectum, the majority of these turned out to have metastases. This, I think, has some moral in that the GU tract and the colon carcinomas have perhaps a little less favorable prognosis, and a lesion appearing on a chest film in the late follow-up is a little bit more likely to be a metastasis as opposed to a breast, particularly if the lymph nodes are uninvolved, or a primary carcinoma of the larynx. In this group of 50 patients, 9 lesions eventually turned out to be benign and unrelated to the original primary. Well, I think in summary, as far as what I have to say about the metastasis is that there are a number of factors which one must take into consideration in making a decision or a recommendation regarding surgical therapy. It's fine in these slow-growing tumor masses in which there's a long interval between the removal of the primary and the appearance of the metastasis, but in some of these in which there is a lesion appearing 2 to 3 to 4 months after the presumably definitive treatment of the primary, it's a bit of a dilemma. We've found these factors to be significant and must be all put together as far as individualizing cases. I think the tumor doubling time has been a big help, particularly in these iffy cases with early appearance or questionable prognosis as far as the primary is concerned, and one must always consider the possibility that when you see an abnormality on the chest film of somebody with a history of carcinoma, that it may be unrelated or it may be a new primary malignancy of the lung.
Paul, there are a number of questions that want to know exactly how you calculate your tumor doubling time specifically. How often do you take x-rays? How is the doubling time established?
How often do we take the films? Since we've gotten interested in the tumor doubling time, we will take the films usually at 1-month intervals for a year, and then at 3-month intervals for the remainder of the 5 years. And then if there's any question about a lesion or if a solitary lesion is picked up, we will do full lung tomography to try to see if we can pick up other lesions which may not be apparent or visible on the routine film. As far as calculating tumor doubling time, you invest about 15 cents in some semi-log paper. At the drugstore, you get a millimeter rule and just measure the transverse diameter of the tumor mass, assuming that it's a discrete mass. The volume of the tumor is a function of the diameter, and for every 50% increase in the diameter, this is a double. So that on the graph, on the left-hand side, you measure the diameter, and on the right-hand side, the doubling, which would be twice as increasing twofold with the diameter, and then plot that against the time and draw a line, and where you get a double the time interval is your tumor doubling time.
And in such a patient, how much workup do you do searching for another primary?
I think
another
you'd
part.
subject this patient to GI serious barium enema, depending upon what the primary was, and do all the things one would ordinarily do to investigate the possibility of a primary elsewhere in the body, IVPs and the whole works.
I gather from the sense of some of these questions, though, Paul, they want to know, given a patient, let's say, who's had a colon cancer removed 15 months ago and a nodule appears, how long will you follow this nodule, both if it grows, to be sure that it's not growing too rapidly, or if it doesn't grow at all, how long do you watch it?
If a lesion appears, how long would you watch it? If it would appear within a year, we would probably watch this for a period of 6 weeks to 2 months with serial films to try to get a doubling time, to try to get a plot of what this is doing. Because if it's doubling rapidly, I don't think you've sacrificed anything foregoing immediate resection of the metastasis, because the prognosis for the rapidly growing tumor is extremely poor. But if it's growing slowly, so that if your tumor doubling time is 40 days or more, then we would go ahead at the end of that period, which would be about 6 weeks. And if we see that this is a slow-growing lesion, we would go ahead and operate. If you even picked up a second, this has happened, I think, 4 times, if you picked up a second lesion and these lesions did still have a slow doubling time or slow rate of growth, we would probably go after both of them.
The next speaker is Dr. Edward J. Beatty, Jr., who will talk on esophageal cancer, combined therapy, and methods of reconstruction. Ted?
Cancer of the esophagus, as we all know, is even worse than lung cancer. It's a very discouraging subject. It is one of our very worst cancers. The actual survival rate in the United States of patients with lung cancer is anywhere, I suppose, from 1 to 3 to 5%, depending upon where you collect your series and what you do. There's no question that it's far better to prevent cancer of the esophagus than it is to worry about treating it. And one of the benefits of the affluent society apparently is that instead of getting cancer of the esophagus, you get cancer of the colon. And I think that's probably a good thing, as you know, compared to cancer of the esophagus. Certainly the people who smoke a good deal and drink a good deal of alcohol are particularly prone to get cancer of the esophagus. And I don't really think I can remember offhand in this country seeing anybody with a cancer of the esophagus who never smoked or drank. It's certainly another one of the preventive medicine aspects. When found, cancer of the esophagus, of course, is usually found in a fairly late stage. At least that's the excuse that surgeons always give when they can't cure cancers. Needless to say, it makes a good deal of difference at what level in the esophagus you get your cancer. The cervical cancers being perhaps more accessible, but actually perhaps just as difficult to treat as any of the others, and the local operation of just taking out the esophagus a la Wookie has not given very good cure rates. The upper thoracic and the mid-thoracic, of course, are particularly bad cancers of the esophagus, not only because they're difficult of accessibility to the surgeon, but they're very prone to involve airway fistulas because of their close proximity to the trachea and the bronchial tree. The lower quarter of the esophagus, actually in our experience, is the least common location for cancer of the esophagus, and it's a bit more readily taken care of because one can do an esophagogastrectomy through the left chest there and get at it quite readily. And you remember Dr. Sweet in his series of patients, when you got them with negative lymph nodes, had quite a respectable cure rate with this particular lesion in the region of 30 to 40%. The real problem, I think, with cancer of the esophagus is that usually the lymph nodes are involved when the surgeon sees the patient, and all too frequently the celiac axis lymph nodes are involved when there's no lymph nodes involved in the thorax, which is a terribly discouraging thing. The other thing is that the cancer of the esophagus is very prone to occur in multiple areas in the esophagus. It's also prone to have rather extensive metastases in the submucosal area. And this is why I think that if one is going to treat these cases either with radiation alone or with surgery or combinations, it's quite important to treat the entire esophagus. It doesn't do much good to just treat a little bit of it. I think it's important to bear in mind that there are really two aims in the treatment of cancer of the esophagus. And by long odds, the most important one, I believe, probably is to try to keep the patient swallowing until he dies. In other words, palliate the obstruction. The other, of course, is to try to cure the cancer of the esophagus, recognizing that we're only going to cure a small percentage, but hopefully we can keep them swallowing in rather a high percentage. Of course, there are two main treatment modalities in attempting to do this. One is radiation therapy, and the other is surgical excision. The other possibility, of course, is a combination of both. Although I hasten to add that generally speaking, radiation therapy post-operation hasn't seemed to add very much to the treatment of cancer of the esophagus. As to whether or not chemotherapy or immunotherapy will be important in the future, I don't know. The Japanese, in the introduction of bleomycin, have great faith in this. This is a new chemotherapeutic agent that's supposed to be particularly effective against epithelial tumors. And my friends in Japan tell me that they think this is about as good as radiation therapy in getting patients prepared for surgery. We're beginning to use this, and I don't really have any personal information yet of any significant series. The diagnosis, it goes without saying, is usually made by esophagogram in a patient who has a complaint of dysphagia. Esophagoscopy and possibly a biopsy, if you can, is the usual way of making a diagnosis. We have been more successful in esophageal cytology in making a diagnosis than we have biopsy. As you know, sometimes the esophagus is obstructed and you can't get down to the tumor to biopsy it. So that our yield of esophageal cytologic examination is about 95% accurate in our hands. And I think this is very important, and it also suggests that it may be a way of following patients who are high risk, heavy drinkers and smokers, maybe ought to have their esophageal cytology checked twice yearly, just the way I think that heavy smokers ought to have their sputum cytology checked twice yearly. And with that, one may be able to find them earlier. Certainly somebody who's got a hiatus hernia, where allegedly with hiatus hernias and peptic esophagitis there's a somewhat increased risk of cancer, or achalasia patients who have dysphagia most of their lives, I think these people particularly should be followed by esophageal cytology twice a year so that you don't get hopelessly inoperable cancers in that group, as has been reported. Needless to say, the bronchoscopy is an important part of this examination, especially of the lesions that are in the upper and mid portion of the esophagus. It's also very important to assess the neck and the abdomen if you're planning radiation therapy or surgery. There's nothing more discouraging than to give 6,000 rads of therapy to mediastinum and then find out that there's cancer in the liver and the celiac axis or up in the neck. So since most of these people are frequently obstructed, why staging by a laparotomy with gastrostomy and checking the abdomen is a fairly important part of therapy before you embark on intensive anything, in my opinion. Some of the figures are rather confusing in results. The best figures that have been reported for radiation therapy, I think, are Pearson's figures in Edinburgh, where he told us that they were treating 2/3 of the patients with therapeutic radiotherapy and not treating 1/3 at all. And in that group of 2/3, they were running as high as he thought a 20% 5-year cure rate, which I think is probably a little bit high. I doubt if you'll maintain it quite that high, and it certainly means that you're throwing out the more unfavorable cases, needless to say. Nakayama is very confusing, as you know, when you try to read his papers, but as I've been over all his figures with him and finally got him sort of to admit to us, he had about 5,000 cases of cancer of the esophagus mixed in with the upper stomach, and he had about 150 cures in that group. And if you do some arithmetic, that's 3%, so we would agree with that figure. If the patient is a reasonable risk, and we think there's a chance of cure, we would now pre-treat the patient with 4,000 to 4,500 rads of radiotherapy. Preoperative radiotherapy was first reported by Gene Clifton Memorial Hospital in New York using 6,000 rads. I think that's a little too high, and I think that one gets too much morbidity from that excessive radiation dose. So if you think there's a chance of curing this patient, we would use 4,500 rads pre-op, followed by surgical excision of essentially the whole esophagus 4 to 6 weeks after the preoperative radiation. Needless to say, that's only done in good risk patients where there's no disease elsewhere, none in the liver, none in the celiac axis, and none in the neck. And we would favor, following that, a 2-stage procedure with a colon interposition operation to reconstruct the esophagus, connecting the esophagus and the neck with the stomach. In a poor or risk patient, perhaps doing this subcutaneously because it's a little bit safer, but ordinarily one can use a substernal location. Needless to say, if that's done properly and you don't get into complications and deaths and so forth, and it's very important to do very safe surgery if you're going to try to cure cancer of the esophagus where the yield is so low, the person at least should swallow to death because recurrence of cancer in the posterior mediastinum or the upper abdomen should not obstruct the new esophagus. We have now collected at Memorial Hospital a small series of 40 patients who have had preoperative radiation, total esophagectomy, colon transplant, and went home, ones that we treated for cure. And to our rather surprise, in this rather small group of 40 patients, 50% of these patients lived 1 to 5 years, and 20% were alive and well at 5 years. And this is mostly lesions in the upper and middle third of the esophagus. So I think that the pessimistic attitude that you can't cure cancer of the esophagus and the upper and middle third of the chest is unwarranted, but you can't cure very many, and they have to be highly selected cases. I think the colon transplant is probably the best way for palliation if you want to use just radiation and get him swallowing again. We have used esophagogastrectomies, but if we do esophagogastrectomies, we've always, at the present time, put those way up in the top of the chest, because here again you want to do as total esophagectomy as you can. It doesn't do much good to do an esophagogastrectomy and then get a local recurrence so he can't swallow after having put him through a rather large operation. The other problem is if you use preoperative radiation, you've got to be terribly careful that you don't sew the irradiated esophagus to the stomach, because this will usually end up with fistula formation, and a leak into the chest will be fatal. And one of the advantages of the 2-stage operation and having an anastomosis in the neck is that the leaks there are usually not fatal, whereas leaks into the chest, of course, are very apt to be fatal.
Dr. Beatty, there are a number of questions relating to timing of your so-called staged procedures. They want, again, description of how long after the radiation and exactly how you do this.
Right. In the first series of preoperative radiation followed by surgery cases that Dr. Gene Clifton reported from Memorial, they were using 6,000 rads of radiation therapy, and with that dose, they were waiting 6 weeks before doing the esophagectomy. I think that's a little too high dose, and we're now using a radiation dose of the 4,000, 4,500 rads, and for that we wait at least 4 weeks, and usually not more than 6 weeks if we plan to do the esophagectomy staged after the radiotherapy.
Ted, excuse me a moment. There's a question here wanting to know specifically how many rads per day you use and whether this is revolving or rotational ports.
No, it's multiple ports, but not rotational, and is given over 4 weeks at 4,000 rads, so you can roughly see it's 150 to 200 rads a day, depending upon how fast the radiation therapist feels he can give it, in that order. Perhaps 175 rads a day for slightly over, maybe for say 5 weeks. As far as when we would do the colon interposition, most of the patients, the colon interposition was done at a second stage after the esophagectomy. However, I think it's optional. We felt that if some patients were particularly good surgical risks, you can do the colon interposition at the conclusion of the radiation therapy and before waiting for the 4 weeks, and so that you can do that before you do the esophagectomy. One of the problems with preoperative radiation, total esophagectomy, and colon interposition is that the patient, if you don't cure him, is apt to spend half his life expectancy in the hospital, which I think is a big detriment to all this multiple procedures. We are going to compare in the future, as I've tried to indicate, the 4,000 rads in 4 weeks with a 2,000 rad dose in 5 or 6 days, on the thesis that what you're using preoperative radiation for primarily is that you don't spread living cancer cells, or at least the cancer cells will not reproduce, they may still be living, and that to shorten this time, to go ahead with 2,000 rads in 5 or 6 days and then go right ahead with the esophagectomy. You don't have to wait at all then, and that has some advantages from a theoretical point of view of getting the job done and getting the patient out of the hospital. I'm a little bit opposed to doing the radiation, the short course, the esophagectomy, and the colon interposition in one stage. I just think that it's been tried and there's been a too excessive a mortality rate. And when you're dealing with a small percent cure, I think you've got to be terribly careful to keep your operative mortality rate as low as possible. An esophagectomy should have a negligible operative mortality rate in a fairly reasonable risk patient, and a colon interposition should be done with, well, under 5 to 10% mortality rate. And I think you've got to do this or you shouldn't be doing the surgery. I think too much surgery has been done for cancer of the esophagus, which has been high mortality rate.
A couple of further questions relate to technique. They want to know, when you do the cervical esophagoscopy, how do you handle the secretions, and if you do a gastrostomy at the time?
Yes.
Excuse me, and also which colon you use.
Well, first of all, at the time one does the total esophagectomy, or essentially total esophagectomy, before you burn your bridges, you naturally make sure that the neck is clear of disease and you make sure that the abdomen is clear of disease if you're going to go for cure, which we presumably are if you're taking out the esophagus. At the time the laparotomy is done, we would perform a gastrostomy and probably do the pyloroplasty at that time. Needless to say, you've done a vagotomy, and we've found that you better do your pyloroplasty, you're going to have problems, and so just as easy to do it then. As far as the cervical part, you want to be careful that you don't get too enthusiastic and cut that esophagus too high in the chest, or you'll find that the cervical esophagus won't even come out to the skin. I mean, you can get pretty high up into the neck through the chest. What you want to do is to have enough cervical esophagus left to bring it to the skin in the lower portion of the neck and really sew all layers of the esophagus to the skin. And naturally all the saliva runs out there, and you can, pin on an ileostomy bag so the fellow isn't so wet and sloppy, so to speak, until you're ready to put in the colon interposition later.
Do you do a barium enema on all your patients before colon transplants?
Yes, very important, because we've had at least three of them where we're going to use them where we found occult tumors in them. And obviously diverticulum might make a problem too.
Dr. Beatty, please comment on the use of Celestin and other type tubes in the management of the palliation.
Many people are very enthusiastic about them, of course, but our experience has been that they plug up, they erode holes, and they migrate, and our experience has been limited mostly to taking other people's tubes out.
I think our time is up, gentlemen.
Thank you, doctors. And this concludes this third edition of Audio Digest Surgery for 1971, produced and copyrighted twice each month, along with 7 other programs in postgraduate medical education on tape recordings by the Audio Digest Foundation, a nonprofit subsidiary of the California Medical Association. Coming up, a program of highlights from the Southern Surgical Association 82nd Annual Session in Boca Raton, Florida, and a special report from the American Cancer Society's National Conference on Cancer of the Colon and Rectum.